I'll just, it's okay if you guys do have questions along the way, if you want to throw something in the chat, or if you want to do the raise hand emoji thing, I'm fine with that. I'm happy to kind of pause along the way if questions come up. Because I want you guys to be able to get as much out of this as possible, and I want this to be useful and informative. So, um, so today I'm going to be talking to you guys about what serious mental illness is, and so what exactly, when I say that, what do I mean, or what is? Oops, sorry, kind of jumping ahead. So, what is serious mental illness, or sometimes abbreviated SMI? Um, you know, because some people might argue, well, isn't all mental illness serious? And I would be one of those people, certainly arguing that point. But when we use this, what we're really saying is, you know, it's a mental illness to the point that it is greatly impacted someone's level of functioning and made it very difficult for them to, you know, continue in school, work, has disrupted relationships, has been very, you know, had a very big impact on their lives. This can include things like depression. So, you know, sometimes, you know, we tend to define depression along a scale of mild, moderate to severe. So on the severe end, depression can qualify as a serious mental illness, severe anxiety, severe PTSD. Um, but more often than not, when we're talking about this, we're talking about a series of disorders where there's you know, an abrupt change in behavior, or some other changes which we'll kind of talk about. So the two main illnesses we're going to talk about today, which are almost always considered serious mental illness, are schizophrenia and bipolar disorder. So first, we'll start with schizophrenia. These are some paintings or drawings I found on the internet, which were all I supposedly drawn or made by individuals with schizophrenia. At least that's what the websites I found them on said. But you know, they really kind of hit at a lot of elements that are kind of common to schizophrenia. On the left here, you see this guy who just really looks tormented, and you see these kind of faces, like ghost-like faces off to his side that seem to be saying things to him, and he, you know, maybe is trying to block them out. You know, in these other two, you kind of see this notion of like heads growing out of other people's heads, and kind of multiple, you know, dealing with all of these different things simultaneously. I think these are, I mean, obviously I can't speak from my personal experience, but I based on the people I've treated and seen, these seem like very accurate representations of what they're going through. So what are some common symptoms that we have used to define schizophrenia? So we usually break these into two categories, positive and negative symptoms. And the easiest way to think of this is positive symptoms are things that are present that ought not be present. And negative symptoms are things that ought to be present that aren't present, if that helps. So positive symptoms include things like delusion. So delusion is what we call a fixed false belief. Now this goes beyond like conspiracy theories. I mean, it's okay if you think that the government was behind JFK's killing. That doesn't make you delusional necessarily. But this is something that's like, you know, you do have to look within someone's culture and their heritage, and is this something that's accepted within their belief system? If it is, then that's not necessarily a delusion. But if even, you know, the people that they trust and know are kind of, this doesn't make sense to us, then you kind of start to worry about that. Hallucinations are basically any sensory perception in the absence of a stimulus. So most often, This is a voice, hearing voices, hearing people talk to you who aren't actually there. But it can include tactile stimulation, so feeling as if someone is touching you, if seeing things, hearing, but most commonly it's auditory in nature, so hearing people talking um, when there's no one present. Another thing you often see is something we call disorganized thinking, where it may be kind of hard to follow this person's thought process and kind of where they're going and how they get from place to place. So most of us, when we're talking about something, we kind of have a what we call a linear train of thought. So one thing leads to the next, leads to the next. Occasionally something might pop out and you're like, oh yeah, no, wait, I forgot about this. This is kind of out in left field, but for someone with true disorganized thinking, almost all of their thoughts are like that. So it's kind of hard to find the through line. And then you can at times see agitation, although it's not actually that common. And the negative symptoms. So these are things like you might notice the person's emotional range of expression being diminished. So even though they might be telling you that they're terrified, they're sad, they're upset, they're worried, the way that their face presents as if there's not really that much, that they're not very concerned about anything. That's not to say that they're not. In most cases, they really are. It's just their outward appearance doesn't necessarily reflect what they may be telling you. Um, so we call that affective flattening. Alogia, which is a poverty of speech, or just kind of not really, not elaborating on things, just kind of very brief, abrupt replies. And then avolition, meaning just basically a severe form of apathy. So just not having a lot of desire to do much, or, maybe isolating oneself and just not having a lot of desire to engage in things like going to class or being around other people. The reason they're all A's is so they're easier to remember. So that's, but these are kind of the hallmark symptoms of schizophrenia. Now, the way schizophrenia usually presents is actually what I think it's most known for are these positive symptoms, but that's not usually what first presents. Usually you actually see more of the negative symptoms, more of a social withdrawal, isolation, apathy, the changes in affect that we talked about. And that will often precede what we think of as the onset of the illness by up to 5 years. We call this the prodromal period. And then you actually have the period where you actually kind of have this active psychosis where the positive symptoms kind of break through and become predominant. And that's usually when people um, come to the attention of providers or families start to realize that this person may need help and start getting them to mental health providers for treatment. With treatment, the positive symptoms are usually the first things to improve, but the negative symptoms can lag behind and can often still be present, even out for a good many, for a while after that. And those are usually kind of the last things to improve. Why this is really important, especially I think for you guys, is that this right here most often occurs kind of in the late teens to early 20s, especially in men. In women, it can be a little bit later. It may be like early to mid 20s when this kind of occurs. But usually there's some signs in the years leading up to that to suggest that something might be going on. But you guys are of an age where you might be seeing friends or people that you're close to or siblings who may be dealing with this kind of thing. And so that's why I think it's important for you guys to know that this, what this might kind of look like, because you're at that age when you might start seeing it. One thing I think is really important, I think schizophrenia in particular gets kind of a bad rap, and people kind of see it as this debilitating illness that there's just no recovery from. Um, and I would really push back on that, that with the appropriate treatment, with the appropriate medication, people can do really well with this illness. And just as an example of that, this is Ellen Sachs. So she is a professor of law at USC. And she is someone who has personally struggled with schizophrenia. I provide a link here for her TED Talk, where she discusses, her experiences with, the mental health system, what that was like for her, how in a lot of cases it was very scary for her, how she struggled for a long time in recognizing the need to be on medications and trying to do it on her own. But ultimately has found stability on maintenance medications and has been able to have a successful life and career. Although she does make clear that it is a continued struggle for her. It's not something that has ever come. It never got easy necessarily, but it is something that she has been able to cope and live a fulfilling life with. So next, we're going to be talking about bipolar disorder. So these are all paintings supposedly by people with bipolar disorder. Many of them were, this is kind of speculation because they existed before our current diagnostic systems did. But on the left, you have Van Gogh, self-portrait. This is after he cut off his own ear, which is thought to have happened during a manic episode, perhaps. Then you have Munch in the middle with the scream. He was also thought to have bipolar disorder. And then on the right, Jackson Pollock is also thought to have bipolar disorder. So how do we think about bipolar disorder? So I think this is probably one of the more poorly understood disorders. And I see this a lot where people come in and they think they have this disorder and they're describing symptoms and they don't really match with what we would consider bipolar disorder. But really when we use this term, what we're referring to is people who have discrete episodes of mania or depression, or you can sometimes have what we call a mixed episode where you have kind of evidence of both simultaneously. The hallmark of bipolar disorder is mania. So if you've ever had a manic episode, regardless of depressive episodes, that's enough to characterize or diagnose bipolar disorder. But more typically, people with this illness experience both and often kind of go back and forth between those two. So mania is characterized by being abnormally upbeat, jumpy, or wired, a very high increase in energy, an exaggerated sense of self confidence. So often this is referred to as euphoria, or sometimes called grandiosity, but a very inflated sense of oneself. Decreased need for sleep. So individuals during a manic episode will often go days without sleeping, or maybe sleeping only 2 or 3 hours a night. They're unusually talkative. Often we call this pressured speech. It's as if they have to keep talking, like they need to finish whatever their thought is. It's very hard to interrupt or get a word in edgewise. They're often very distractible, often going from one thing to the next. And usually what makes this disorder problematic is that the people in this state are often have a very poor sense of the fact that they're in that state. They're not they have very poor insight into the fact that they're manic. And they often will do things that are very uncharacteristic and a lot of times unsafe. So they may go on spending sprees, run up credit cards. They may take risks that they wouldn't normally take in terms of having sexual encounters they wouldn't normally have, or just doing things that, like putting themselves in harmful situations that they would normally know better than to do. Um, Mania usually lasts for anywhere from days to weeks. Um, and then this is kind of how a typical course of bipolar disorder might look like. It often will start earlier on as episodes of depression, and then sort of might have a manic episode followed by more periods of depression. Um, there's no one specific course. I mean, like I said, some people only ever experience manic episodes, never really have depressive episodes. Some people switch more rapidly and will go kind of back and forth between episodes more rapidly than it's depicted here. But this is sort of a typical course. And I would say the majority of cases actually spend more time in the depressed phase than in the manic phase. And again, just there's a lot of folks who live with this illness and do so very successfully. As an example, Kay Redfield Jamison, she's a psychologist, and she herself has bipolar disorder. She wrote a memoir about it in the mid 90s. But this is not, again, this is something that if treated, people can do really well and can live a reasonably normal life. So, one of the reasons in talking about this topic is, I realize you guys are, as mental health ambassadors, are really, wanting to, be there for other people, your classmates and everyone, and wanting to support them and kind of knowing how best to do that. And I think, there's a lot of great ways to support someone, but if they're going through something that is, like schizophrenia, like bipolar disorder, where there may be manic, sometimes, you might feel a little out of your depth or out of your comfort zone. And so how do you approach that? How do you approach someone that you're concerned about, but maybe isn't receptive to your support because they don't think there's anything wrong, or they don't, have they don't have the insight that you do that there's something that needs to be addressed. So one thing you can always, even if even if what they're saying to you doesn't make sense, you can always empathize with their struggle. So even if they're telling you things that aren't true, you can always say, well, even just feeling that way must be terribly difficult and something that you must really be struggling with. Letting them know that you are there for them, whatever they need. And then where you can, encouraging them to seek help. I get other people involved if you need to, whether that's an RA, a professor, someone from student life. But if you have real concerns, someone is really acting not like themselves, you have concerns for their safety, never hesitate to get them the help they need. So whether that's contacting campus security, the police, taking them to the nearest emergency room, a lot of times they're going to be in a place where they're not going to be able to recognize the need for that help, that level of help. So don't be afraid to do that. One thing that, so the way that Dr. Lanzi and I actually know each other is we serve on a task force that's kind of UAB wide. And one of the things that our task force is put together is this UAB Cares website. So this is a website that anyone can go to that can kind of guide you, hopefully, in the right direction of how to get help. If you're a student, it has a place for you to pick. If you're an employee, if you're concerned about someone, you can get help now. If you click on those, it'll tell you basically what I've already told you. Call the UAB Police Department, call 911, get to the nearest emergency room. In the case of students, there's the Student Counseling Services. If you go to that website, they also have a crisis and emergency page. So again, in life-threatening cases, dial 911, UAB emergency department, get them to the nearest emergency room. But there's also same-day crisis appointments or next-day urgent care appointments. So there are other options if it doesn't, if it doesn't quite rise to that level of need just yet. And then they can kind of help guide that person on what the next steps, might be. And with that, I think that's really all I had. I just kind of had some resources here, but again, most of these are the UAB Cares website and the Student Counseling website. I'm happy to take any questions or anything that you guys, yeah. All right, not all at once.
Howdy. I came in late and missed the first part.
That's all right.
Oh, I see that you're recording this. Oh, so this will be uploaded later.
I'll defer to Dr. Lancy on that one. I assume so.
Okay.
Hey, my name is Lavanya. I'm on the leadership team for Mental Health Ambassadors, so Dr. Lindsay had to step off just for a second, but I will be helping manage the rest of the session. So yes, we will be placing this recording probably on Canvas or something so that you guys can review it again. But does anyone have any questions for Dr. Pruett in the meantime? You can get some participation points that way.
And I also realized I didn't actually introduce myself. So I'm actually a psychiatrist here at UAB, and I mainly treat patients here who are hospitalized here with psychiatric illness. And then I also split my time and I do some research as well in the Department of Psychiatry. So.
Awesome. Thank you so much for introducing yourself, Dr. Pruett.
At the end of the talk.
Anyone
and it can go beyond this as well. I mean, if there's other things you guys are, have questions about, happy to engage in the discussion, whatever that may be.
I have a question. Is my mic working?
It is.
Okay. What's a good way to empathize with someone who is going through like an anxiety attack or a panic attack and help them in that situation?
A great question. Okay. So, well, again, I think it's just letting them know that you're there for them, that you are going to, that you realize that this is very uncomfortable for them and that they must not feel very well. Things that are usually really helpful when someone is going through panic symptoms is something called grounding techniques. So this is ways of helping them essentially get out of their own heads. So have them kind of focus on their feet and how they're connecting to the floor. Have them focus, if they're seated, have them focus on what it feels like for their hands and their arms to be on the armrest. What does it feel like for your back to be against the chair? All of these things are ways of kind of helping ground them in the moment and get them out of that kind of repetitive cycle of anxiety. So those are ways too that you can help someone like, hey, focus on me, focus on being here in this moment. Focus on how your feet feel planted on the ground. Focus on the sounds around you and what you're hearing. Tell them back to me. The other things that are helpful with anxiety, in particular panic disorder, panic attacks, is recognizing that, in those moments, they feel very, very, you feel very out of control. You feel very, just like you feel as if you might die. but recognizing that it's not actually going to go on forever, that it's actually very limited in time. And if you can ask them to kind of come back to that again and again, okay, rate your level of anxiety out of 10. And in the middle of the panic attack, I guarantee it's probably going to be 10 out of 10. But as you're doing those grounding techniques with them, come back a minute or two later, okay, what's it now? Well, you know what, now it's 7 out of 10. Okay, let's work on this some more. What do you hear now? What are you focused on? Come back, it'll be a 5 out of 10, you know. And as they start to kind of recognize that too, that also kind of helps, because now they have a more of a sense of control of the situation, knowing that they're, you know, this isn't going to go on forever, that it's something that they can kind of get through. Does that help?
That was perfect. Thank you.
Sure. And there was a question in the chat that was basically, oh, actually, there's been a lot of questions since
yeah, there's 3 questions. I can go ahead and ask the first one for you so you don't have to go through the chat again.
Sure.
So the first one is actually from Elena, and she asked, is it possible to inherit schizophrenia or bipolar disorder?
So the short answer is yes, but it's pretty complicated. So it's not, there are some disorders that, you know, we call them recessive or dominant. If you carry the trait, you know, if it's dominant, if you have the gene, you will express the illness. Or if it's a recessive trait, if you have 2 of them. So if you have 2 mutations that cause cystic fibrosis, you will have cystic fibrosis. These illnesses are much more complicated than that. I think anywhere from like 100 to 200 genes have been implicated. And the role that they play, like they explain about 10 to 15% of overall cases. So do these travel in families? Do you see, you know, family trees where multiple members have bipolar disorder and schizophrenia? Yes, but it's a very complicated, you can't, there's no way to say just because this family member did that this family member will as well. And then there's also an environmental component.
So it's kind of like cancer in that way, where sometimes cancer can be something like that people are more genetically going to get because of who they're related to, and then sometimes it's completely unrelated.
Absolutely. It's similar to heart disease too. Like that's another one where the transmission's really complex. But one of the ways we think about this is that there's kind of there's a genetic component, which like I said, is maybe about 10 to 15% of it. And then another piece that's environmental. And so it's this interplay between genetically vulnerable and certain environments that seem to come together to produce this illness. And it's almost certainly things that are happening very early on in development. So there's a lot of things having to do with even like prenatal, or how someone developed, you know, were there complications? Did the mother contract the flu during her pregnancy? Those sorts of things. All the way through can kind of, so it sort of starts with the genetic vulnerability, but if in the absence of these environmental stressors, you may be just fine. And then, and I mean, it even gets to the point where, so if you have identical twins, there's a very high chance if one of them has schizophrenia that the other one will have it, but it's not 100%, it's only like 60 to 80%. So, I mean, so you can't explain it all by genetics. All right.
Thank you so much for taking the time to explain that. We have another question from Sarah Ann. She asked, manic periods have to go on for a certain amount of time to be considered as a symptom of either schizophrenia or bipolar disorder, correct?
Yes and no. So there's not necessarily a specific time frame. I mean, they would need to go on for at least a few days typically. But then there's also something we call hypomania, which I didn't really get into in this, it has all the same hallmarks as mania does, but it doesn't, it's kind of a degree lower than mania. And usually people are able to function in their jobs and in their lives, but there is like a noticeable difference in their behavior. And that kind of complicates things, because that doesn't necessarily, that may last a day or so, and you could still sort of consider that. So generally speaking, yeah, it probably would need to last for, at least several days for us to consider that a true manic episode.
Okay, awesome. We have one more question that was asked in the chat previously. This is from Justin, and he asked, if someone were interested in seeking treatment, would you recommend them request an appointment with a psychiatrist first or a therapist and work their way up the chain?
Oh, that's a fantastic question. I don't, I guess I would say it depends on the severity. If it's, if it's kind of what we're talking about here, and you're thinking someone, well, I'll put it to you like this. So if someone is really having symptoms like the kind I described of schizophrenia or bipolar disorder, like true manic symptoms or true psychotic symptoms, while they may benefit from therapy, they are going to need medication to stabilize. And so in that case, I would suggest seeing a psychiatrist first. In the absence of those kinds of symptoms, though, they may or may not need medications. And in those cases, just being in therapy may be enough to help them, improve. So I guess there's probably not a one-size-fits-all approach.
Okay, awesome. Yeah, I think that is a great question, especially when people do approach ambassadors with an issue. For example, if the ambassador is not sure where to direct them, that was a great answer. Thank you so much for that.
Well, and you can always refer folks to the student counseling. And if they realize it's something that they're not going to be able to address there, they're going to be able to get them. So I don't want you to, if you just cold call a psychiatrist, you might be waiting several months to get in to see someone. So I guess I would amend my answer to say, get into the person that you can get into the soonest, the quickest. And in almost all cases, if they're not the right person, they're going to know how to get you to the right person.
Right. Well, thank you for answering that question. I think Laura had another question. Laura, you can go ahead and ask your question.
I had a question. This pertains to our mental health. What are some ways that we can what are some like healthy coping mechanisms we can use if we find ourselves depressed during college or especially the pandemic?
So let me just first say, and I actually intended to bring this up before I even started the lecture, but this is such a difficult time right now. For all of you guys, I get that. My wife is a master's student actually here and is teaching some first year English courses. And, I get the sense of how, doing everything via a screen, and you just don't get that same sense of connection and camaraderie and all the things I imagine you were expecting you would get going to college. So I get that this is such a strange and unusual time. So first off, I would just say, guys, cut yourself some slack. Like, this is nothing about this is normal. And I get Zoom fatigue. I know everyone else that I talk to gets Zoom fatigue. It's so hard when all of your classes are online and all of your interactions are via video. And it just gets so, like, I find it difficult to concentrate and to pay attention and to things that wouldn't have been that way if we were in person and I were like directly listening to someone talk. So I think it starts with cutting yourself some slack and saying it's okay. Like everyone right now is going through this, and it's not easy for anyone. And then I think just kind of being cognizant and recognizing that some ways that you can kind of, so I think probably the best thing you can do is have a schedule. So having a set schedule of what you're going to do each and every day, having some structure to your life is always a good thing. And that always kind of helps at least keep things a little more normal. Staying as connected to other people as you possibly can, even though I know how difficult that is. Making sure that you're reaching out to people and letting them know how you're feeling about all this. I think those are probably the biggest things I would recommend.
Awesome. Thank you so much. Does anybody else have any questions for Dr. Pruett? You can type it in the chat or just use your mic to ask them. Do you want to give them a minute, Dr. Pruett, just to see if anybody comes up with any questions?
I'm happy to.
Okay.
So how has it been going?
For like mental health ambassadors or?
Just like school in general, like.
Like me personally or just anybody?
Open it up to the floor, whoever wants to.
It's crazy.
Yeah, it's very true.
Like for me, I was already doing online high school before the pandemic hit, so it wasn't that difficult of a change for me. But it's the fact that I feel like I haven't moved on from high school because of that. Because I'm just doing the same thing with the online classes and not going anywhere. So I feel like I have been stunted by this. And I know I'm probably not the only one that kind of feels that, like,
no,
you know.
Of course not. No, but I totally get that. How that, yeah. It's, I mean, I think that's where just reminding yourself that everyone is having that experience right now. And I don't think when we get through this to the other side, I don't think, it's going to be something that's part of our collective experience. So no one's going to question that, like, your first year of college was difficult and was not what anyone expected.
Thank you for answering my question, by the way. I didn't get to tell you that because my cat jumped up on my computer.
No problem.
Anyone else want to talk about their experience right now? I will say for me, I think classes have been a little harder just because I think teachers are expecting us to do a lot more outside of class on our own. So it's become a lot more independent work. And that's fine. I mean, that's what college is about, learning how to do things yourself. But when it comes to like having to teach yourself organic chemistry, for example, I think that's been difficult for me personally.
Yeah.
And like anatomy right now, which I'm taking, we don't get any like in-person components for the most part. So everything is like virtual. We have to learn it like that. And
that's so tough. Yeah, no, I mean, yeah, you learn anatomy by like being the anatomy.
By seeing it in person. And it's even worse for med students, I'm sure. I think a lot of them are doing virtual med school right now. So that's crazy to even imagine.
I didn't even think about how organic chemistry is probably, because I'm an art student. So it's been difficult for me just because it's hard to get instruction from a computer when usually, you're making stuff with your hands. But I didn't even think, oh my gosh, it's probably for people who are supposed to be doing dissections right now, that hands-on experience is really important, and it's kind of sad we're losing out on that.
Yeah, no, I think the other thing that's important, you know, is I think you kind of have to think about this like as a grief reaction, like that this is like, I think everyone's, at least I can speak for myself, like when I was in college, I came to college with certain expectations of what that experience would be. And if I found myself in the situation you guys are in, like that would be vastly different than what I went into it expecting. And kind of, you know, so I think you have to give yourself the space to mourn that loss, that it's, you know, um, that it's not what you were hoping it would be, and that it's not going to be at this point. That hopefully it can get back to that, you know, in the next year or so, maybe. But allowing yourself that space to grieve it, like because it is a loss. It's a loss like any other.
Yeah, that's a very good point. I think Dr. Lindsay always makes a statement during her meeting. She's like, give yourself grace and give others grace, because it's something that I feel like we don't really do very often. I will say, like, with these online classes, it's harder because we're trying to teach ourselves these things and we just get frustrated or lazy. And that is kind of what's happening with a lot of my own peers, for example. You know, we just don't have the same motivation that we used to have doing things online or at home or wherever we're from, wherever we are right now.
And I think that's where I would, where I would push back is I would say, I don't think you guys are being lazy. That's part, like I would say, give yourself the grace of saying that when you're not motivated to do something, that's not laziness. That's, you know, a response to what you're going through, and that's okay.
Yeah, that's a very good point. I feel like we tell ourselves we're lazy, or our parents might say something, or our peers or teachers might say, like, you guys are lazy or something, which has happened before, but this is a different situation. So like you said, I think that's a good point, that everyone should remind themselves to give themselves grace, like Dr. Lindsay says.
I think that's, yeah, I would 100% echo what Dr. Lindsay says on that. Absolutely. All right. Anything else, you guys? I can talk all day, so. I actually can't. I do have to be somewhere too, but.
Oh yeah, you're good.
I'm free to talk until then.
Well, thank you so much for taking the time to present to us and answering all of our questions and conversing with us as well, giving us your advice and everything. We take that definitely to heart, and since we're recording this session, we'll have the other mental health ambassadors watch this as well, so they can get a chance to see what you got to present to us and the amazing advice you gave us. So we really appreciate it. Thank you so much.
And thank you for having me. It's been a pleasure. You guys take care and give yourself grace.
Thank you.